Next, we have a short case presentation on the topic Diabetic Food for Amputation by Dr. Muthu and Dr. Shweta. The internal examiner will be Dr. Dhivya Mariam Jacob, Assistant Professor of KMCT Medical College, and the external examiner will be Dr. Joan Chirayath, Associate Professor and Clinical Lead for Critical Care Unit at Amala Medical College, Thrissur.
Good afternoon. A small disclosure. Actually, Dr. Dhivya had called me a few weeks back about the case, and what I had told them was, I'll see the case today, and let's see what happens today. Okay, so they actually don't know any of the questions, so it's just going to be blind. So on that context, let's start. First question will be, suppose this is a short case, 20 minutes. What might be the first question that comes out of the examiner's mouth?
Give me a short summary of the case.
Please tell that. Short summary of the case and your diagnosis. Okay.
Good afternoon, all. So, summary, 54-year-old female, non-case of type 2 diabetes mellitus, on irregular treatment with oral hypoglycemic agent, now presented with fever for 1 week and non-healing ulcer near the heel of right leg, increasing since 1 month, associated with absent peripheral pulsations, vibration sense, and skin changes with orthostatic hypotension. Diagnosis, 54-year-old female, non-case of type 2 diabetes mellitus, complicated with diabetic peripheral neuropathy, on irregular treatment with oral hypoglycemic agent with right diabetic foot, posted for below knee amputation.
Okay. So you said irregular treatment.
Yes.
Should I wait? Should I wait for the surgery? Do I have time to prolong the case?
Prolong.
Since it's the amputation surgery, we can post in the emergency.
Okay. Does it fall under the emergency criteria?
It's a limb-saving surgery,
Yeah, it's not a leg-saving surgery, but it's life-saving. If the patient is in sepsis, within 6 to 12 hours, the source should be controlled. So is it a dire emergency? Probably not, but it is definitely an urgent surgery. Within 6 to 12 hours, unless the source is controlled, the patient is not going to get cured. When they call up with regards to this patient, they call you up, you are on call. What are your concerns? What are the anesthetic concerns or considerations that you're having for this case?
Since it's a long-standing case of diabetes and it's also uncontrolled, so I'm mainly concerned with the complications of the diabetes, mainly the acute complications and the chronic complications.
Okay.
So the acute complications include diabetic ketoacidosis, hypoglycemia, lactic acidosis, and HHS.
Yeah.
Then the chronic complications, it can be either micro and macro complications.
Yeah.
Micro complications, already the patient is having neuropathy, then retinopathy, nephropathy. Then,
so just breaking in between, you said that this patient has neuropathies.
Yes, sir.
Okay. Why is that autonomic neuropathy? Why should that concern you?
Autonomic neuropathy can affect different organs.
Yeah.
Its cardiovascular system has resting tachycardia, exercise intolerance, and it can present with silent MI also.
Okay.
And in gastrointestinal system, gastroparesis, esophageal dysmotility.
Okay. So what are the things in the history that might tell you that this patient has autonomic neuropathy?
This patient has already orthostatic hypotension.
Okay. Well, will the patient tell you that the patient has orthostatic hypotension? Yeah.
In clinical examination, we got
anything, if the patient has really really orthostatic hypotension, is there anything in the history that might actually pinpoint towards that?
numbness.
Autonomic neuropathy?
neuropathy.
So basically,
Feel-
syncopial attacks. Okay, if the patient has syncopial attacks, that might be a possibility. If the patient has numbness, if there is peripheral neuropathy, usually it is associated with autonomic neuropathy. So you can actually still think and probably go into the depths whether the patient has autonomic neuropathy. What else in the symptoms? Autonomic neuropathy, because that's quite worrying. If the patient has a cardiac problem, how will they present? Will they present with angina?
No,
No, it's silent. Pain is
Silent?
not.
Yeah, usually pain is not. So what is?
Silent MI.
That's if they had an MI.
MI.
What about if they haven't had an MI? It might be breathlessness. Okay, they might just be breathless. Okay, so excised intolerance might be something that you want to pick up. Anything else? Orthostatic hypotension? GIT?
In aspiration.
What might be the
diarrhea,
symptoms?
diarrhea, constipation.
Diarrhea, constipation, those things can happen. Anything else?
Dry skin, skin changes, scleroderma,
Or sweating.
heat intolerance,
Sweat-
anhydrosis.
Yeah, sweating, differential sweatings.
Yes.
Okay, if that is a complaint, then probably you can think about orthostatic hypotension. Okay, so you said acute and chronic complications of diabetes. You said autonomic neuropathy as one. What else? What else am I concerned? Anesthetic considerations.
Macrovascular complications.
Yeah, okay. Macrovascular complications affecting other organs. Yeah, okay. What
Coronary
else?
artery disease, cerebrovascular.
Okay, yeah. Infection?
High chance of
Okay, so
infection.
what?
Hypothermia.
Yeah, that is again, if somebody is has autonomic neuropathy, hypothermia is very, very important. Infection. This patient very likely has infection. What are the things to know infection?
About the
Okay,
investigations.
it's there in the
we'll order
investigations,
for
correct?
We'll order for a complete.
Any names of any scores? When somebody says infection, sepsis,
Yeah.
okay, so this probably
SOFA.
SIRS, Q SOFA, and things like that and all. That actually, it's like in the science, it is there. Okay, you don't need an investigation. Only, only WBC counts in SIRS needs an investigation. All others are science, isn't it? So that is, again, my concern. Okay, yeah. So with these concerns, this patient is coming to you. How are you going to preoperatively prepare this patient? What are the investigations that you are going to ask for? And why do you need each of those investigations?
Investigation, I'll start with the complete blood count.
Okay.
In that, I'll check for the hematocrit
Yeah.
to know the HB, the rule out anemia.
Why
and
should
to
there be
arrange,
anemia?
Already.
Blood.
Why should there be anemia in this patient?
Nutritional deficiency.
Yes, nutritional deficiency is a chronic disease.
Chronic
Nutritional
disease
deficiency is it's a possibility.
Possibility.
Again, he's having an infection most likely.
Yeah,
So
that-
because of that, again, erythropoiesis will get affected. Okay, what else?
Then coming to the total. Other
He might have other system
Yeah,
anomalies.
anomalies.
Which system might cause chronic anemia? Mainly renal.
Renal
Yes,
system.
if he has renal failure. Okay, as of now, we don't know, isn't it? So if he has renal failure, that can cause chronic anemia. So there are quite a lot of reasons for anemia. Okay, what else on the whole blood?
total count to
Why
look for the
total count?
infection and sepsis.
And what are you looking in the total count?
Neutrophils.
Neutrophils, whether there are high neutrophils in the total count. Yes, anything else?
Then platelet we can
Okay, yeah, why platelets?
for giving the
Regional.
anesthesia.
Why should the platelets be low?
Liver parameters and
Liver in, is it something more common? He's having sepsis, isn't it?
sepsis,
So that itself can bring down the platelets. Okay, probably liver, yes, it's a possibility, but the patient should have liver, should be that sick to have liver problems and then, okay. But it's a possibility, yes. What else?
Then we can order for an RBS and HbA1c.
Yeah, okay.
know.
What sort of values are you looking at?
HbA1c,
How much was this patient's value?
it was 300.
300 was the RBS, okay.
Yes.
What sort of, okay, HbA1c. Tell me something about HbA1c.
HbA1c, the glycosylated hemoglobin,
Yeah.
that will give the control of sugar values over the past 8 to 12 weeks.
Yeah.
So it should be between 5 and 7.
Okay. So when will you not accept a patient?
Above 9
9,
and below
below
5, we
5.
won't accept.
Will you not accept the patient?
Optimize.
How will you
try to-
optimize? Will I wait for 3 months or 18 weeks or something like that to optimize? Not 18 weeks, around 3 months, 2 to 3 months.
If it's an emergency surgery, high risk, we will post it under.
Again, it's said like that, okay, you're not wrong, it's said like that, but I don't know why it is said like that. Okay, maybe one of the things is you can tell the bystanders that this is not, because the outcomes were supposed to be slightly worse when it was not under control. So you can tell the bystanders it's not under control, but we don't have the time to do it, because which surgery can you postpone? Even if it's a hernia, which needs surgery, how can I postpone a case for 3 months and say that it won't get obstructed in between? Okay, so and how many patients do we see who have a high HbA1c and we still do it? Okay, so I don't know this thing of that. Anyway, okay, what else?
Then serum electrolytes.
Serum electrolytes. Why do you want serum electrolytes?
Patient may insulin therapy, potassium level can.
Okay, so why should the potassium level be high in somebody in a diabetic? What might be the reasons why the potassium is high?
Diabetic ketoacidosis.
Diabetic ketoacidosis. So why in diabetic ketoacidosis the potassium should be high? So when there is acidosis. So when there is acidosis, the shift between hydrogen ions. Okay, so because of that, that's one reason. Insulin is deficient. Again, the potassium stays out of the cells.
Extracellular.
Another reason. Okay. What happens with regards to water? What happens when somebody is diabetic?
Water.
Well, they are water
Diuresis.
depleted. Okay, so electrolytes again can be abnormal. Okay, so mainly for the first two reasons, potassium might be high. Okay. What about sodium? Does sodium tell us anything in diabetes? So actually, when the sodium goes up very high, when the glucose goes up very high, sodium comes down. So for around 100 of increase in glucose, sodium comes down by around 1.5, 1.6. So if somebody has a normal sodium or a high sodium with hyperglycemia, the patient is probably water depleted. Okay, so that tells you that the patient is water depleted, dehydrated. Yes. Okay. What else? What else in the investigations?
Renal.
RFT.
Yes. Yeah. What in RFT?
For nephropathy.
Yes. Nephropathies. Yeah. What else?
Other investigations.
Yeah. What other investigations do you want?
I'll ask for a chest X-ray, routine chest X-ray.
Okay. What specifically? 54-year-old.
52-year-old.
Pardon?
No.
Yeah, actually, none of the guidelines tells us. We all do it,
Okay.
maybe. Most of the hospitals does it. But none of the guidelines actually tell that a chest X-ray is indicated if there is no sign or symptom. Okay, yeah. If the patient was breathless, then yes. Okay, yeah. What else?
ABG.
When I say just going back a little bit, breathless, how can you assess the exercise tolerance of a patient?
We can ask for the 6-minute walk test,
Okay.
shuttle walk test, stair
Okay.
climbing test.
Do you do that in your institution?
6-minute walk test we do. Breath holding test.
You do it, okay? Yeah, every patient you do it, PAC.
If METS is less than 4.
Okay, what if METS? Okay, tell me something about METS. What is METS?
Metabolic.
Yeah, so what sort of metabolic equivalent are you happy with?
More than 4, I'm happy.
Yeah, so how do you say that somebody
If
has
the
more than
patient
4?
is able to climb two flight of stairs.
2 flight or a flight?
A flight of stairs.
Okay, there's a controversy actually, because abroad the height of the second floor is low, so there is a single stair. Here it is high, so we have 2 stairs. Okay, so our flight might be, so nobody, I don't know. So our flight might be, because when you say flight, it is from one floor to the next floor. So around like 12 is one flight. 10 to 12 is one flight. So I would say getting to the next floor, if they have any problem, then it is less than 4. We don't know exactly. Okay, so then we'll dig into. Okay, if it's possible, then that's a reasonably good exercise tolerance. What does METs have to do with, what is 4 METs? What is 1 MET?
3.5
Yeah, amount of oxygen consumed when?
healthy.
So amount of oxygen consumed when the patient is at rest.
At rest.
And that is around 3.5.
ml.
Okay, so 4 METs is around 3.5 into 4 is 7, 14. Around 15 in your cardiopulmonary exercise testing, 15 Vmax is actually quite good. So this actually 14 corresponds quite well. So that is why 4 meds is supposed to be good. Okay, yeah. So then coming back, investigations, what other investigations do you want?
ECG and
Okay, do you need an ECG in this patient?
yes.
Yes, there is a reason why you need an ECG. Okay, what else?
Echo.
What are you looking in the ECG?
Any ST
Silent.
silent MI can
Whether he has had any silent MI in the past, what
ST
else?
Arrhythmia scan. Arrhythmias.
Any arrhythmias, okay, fine, yeah. Potassium is high, so you can look at things with regards to potassium, a T wave and things like that and all. Potassium might be high, not is high, okay. Okay, what else? What other investigations?
Echo.
Echo, why echo?
Because patient is having complications, chances are very high.
Correct,
So
uncontrolled
Diabetic.
diabetic, not on regular treatment, posted for an infection. So yes, I would like to have an echo. Yeah, what else?
Then ABG,
Okay, why do you want an ABG?
because the RBS we did was
Yes.
300.
Yes.
To rule out
Okay.
the-
to rule out DK.
Okay, yeah, fine.
Then
urine
routine examinations
Okay, fine.
also.
Yeah. Okay, so then I'm just going a little bit fast, not going too much into it. Other things are probably other investigations of infection, a CRP or a procalcitonin, depending upon how neutrophils are high. Okay. Yes. Okay, so what are you going to be your orders for this patient is coming for the surgery? Suppose if the patient is coming for the surgery the next day morning, what are going to be your orders?
Next day morning, so I'll probably post this as the first
First
case.
Yes,
And
first
will
case, yeah.
skip morning dose of OHA. Then
and yes.
Okay, so which OHA, like regarding OHAs, which OHA will you skip, which one will you not skip, or do you skip everything same time?
Usually
Usually-
metformin will be 20 minor surgery 24 on the day of surgery.
On the day of surgery, you skip it. Okay, yeah. What about the others?
for me, just
Sodium transporters we
Yeah.
will skip 24 to 72 hours.
Yeah,
prior.
some say even 72 hours. If you have time, 72 hours. Do you want any questions to be asked? Are you sure? 72 hours, yes. Why?
Euglycemic ketoacidosis.
Glycemic. First of all, the half-life is around 12 to 16 hours. Okay, so that's one thing. So it stays a longer time in the system. Only half-life is 12 to 16 hours. Second thing is that euglycemic ketosis is common, okay, with those. So that's why that some of the recommendations are even up to 72 hours. Okay, fine. What about sulfonylureas?
We'll skip
Skip just the night, just the morning dose, or
morning.
some books say even the previous night dose. But again, because we keep on monitoring regularly afterwards, that's why it's not a big issue. But the recommendation is probably skip the night dose as well, sulfonylureas. Okay. What is the issue with metformin?
It can cause lactic acid.
Okay. Is it common? Is it common?
Not.
I haven't seen one myself, so that's why I was asking, is it common? Okay, it's not at all common. Okay, and it's especially seen in patients who are otherwise sick, cardiac and especially nephro. Patients who have had metformin, the metformin won't go out of the system, it will accumulate and it can cause lactic acidosis. Okay, yeah. Okay, so these are the things that you will do. Yeah. What are your anesthetic choices? What sort of anesthesia are you going to give to this patient? And just tell me briefly about why one versus the other one.
for this patient, I'd probably prefer regional anesthesia,
Okay.
probably the block,
Okay.
because the reason patient will be awake, I'll be able to
Okay, so you are planning to do a regional anesthesia. What sort of
Regional
block will you give for this patient?
popliteal block, USG guided.
As
Okay.
became.
Will that be enough?
Yeah, it's just half an hour surgery.
Minor
Will a
procedure.
popliteal be enough for doing a BK amputation? What about this part of it? So will the popliteal cover saphenous? So what is popliteal saphenous a branch of? What is saphenous a branch of? Saphenous is a branch of femoral.
Femoral.
Okay, so you need a femoral
Femoral
or saphenous block with that. Where do you give a saphenous block? Popliteal block, you're going to tell me that you're going to do it behind, isn't it?
Yes.
Yeah, isn't it? Okay, fine. Yeah, okay, I agree. A little bit higher up behind might be okay. What about saphenous? Where are you going to give the saphenous?
Adductor.
So Savin is actually subcutaneous here. Will that be enough?
No.
Why? Because the amputation is here.
Uh,
So
Below.
what about this? That might be enough, isn't it? It's usually not enough. Okay, because the sensory, some of the fibers might have come from the top. So the safe thing would be, probably you can do your popliteal sciatic or even a higher sciatic and ephemeral. Okay, that will be much more safer. Okay. Yeah. What else? Okay. What about a spinal?
Spinal.
Unilateral.
Already the patient.
What might be the problems against the spinal? When these patients come, usually spinal is not an option. Why?
Profound hypotension.
Why?
Already
Central.
the patient is having orthostatic hypotension. so
Autonomic neuropathy.
Okay,
For
autonomic
hypertension
neuropathy is
is
there.
there.
Yes, autonomic neuropathy is there. The patient might be having cardiac problems, sepsis. So, and usually their coagulation will be deranged. So because of that, spinal might be a problem. Okay. Is it a highly risky case or is it a safe case?
Same case, it depends upon
upon
the blow. Since if you are being blow,
Can I take 2 more minutes probably? Is that okay? Yeah.
it's not at high risk.
It is
It's
quite a risky
quite
case. Okay. Evidence says that around 60% of the patients who have had an amputation after 5 years are not alive. Okay, after 5 years. Okay. In the theater, among all the, if you list like hernia, CABG, amputation, this is one of the group of cases where maximum perioperative deaths have happened. Okay, so perioperative death is a death around sort of up to 24 hours after the surgery. Okay, maximum number. So it's actually quite a risky case. So when this case comes, apart from all your standard ASA monitors, will you think about, you're doing it under a block, will you think about any other monitor? All your standard ASA monitors, or sir was saying Indian monitors, yeah, so the 4 of them, yes, that is there. Oh, not the 4 of the 3 of them, because you're doing a block. So you don't need an ETCO2. What else?
In BP mode.
Will you put an invasive blood pressure for this patient?
Actually, ideally since block it is not.
I actually will put. Okay, it all depends upon how bad your other things were. Like if the patient was in sepsis, if the patient was in having any cardiac problem on the echo, this is one case where I'll put an arterial line. And I won't send this, even if it's a block, I won't send this patient to the ward because he might be having his first MI that night. Okay, why might he have an MI later that night? What might be the reason? You have saved him, isn't it? You've amputated. Because the surgical insult will cause lot of procoagulants and inflammatory things and all, which might cause a perioperative MI. Okay. Is your perioperative MI, suppose I give you an option. Somebody has a perioperative MI or somebody has a normal MI, a thrombotic or an embolic MI. Which one will you prefer?
No, normal.
Yes, because that is a one-time insult. Here, the insult is staying.
Okay.
The inflammatory markers are going to be there till the cure happens. Okay, suppose it's surgery, that is why perioperative MI has a higher mortality. Okay, because you're not cutting off the problem. Did you get me? Yeah. So yes, I will monitor this patient and take this case quite seriously. These guys have done extremely well, okay. It was like a rapid fire and no questions were shared. So it was actually, they've done it quite well. You did come through it without any issues. Okay, thank you. Thank you, Dr. Dhivya.
Thank you, sir.
Thank you, doctors. Now, I request Dr. Joe John Chirayath to distribute the participating certificates to Dr. Muthu and Dr. Shweta. Now, I kindly request Dr. Anil Kumar to come onto the stage to felicitate Dr. Joe. I also request Dr. Shamshad to please come onto the stage to felicitate Dr. Dhivya.